Bismillahirrahmanirrahim. Assalamu alaikum and hi my friends. As we have started the series of eye, today our topic is ptosis. So what is ptosis? When the upper eyelid comes to abnormal lower position, this is called ptosis. So the drooping of upper eyelid to abnormally lower position, this is called ptosis. For example, if this is the upper eyelid and it comes to the abnormal lower position and covers the cornea, it will be called ptosis, which is also called blephroptosis. Okay. Now we have two types of ptosis: congenital ptosis and acquired ptosis. Congenital ptosis is also of it is of three types: simple congenital ptosis, Marcus-Gunn-Jaw-Winking syndrome, and blephropymosis syndrome. So, what is simple congenital ptosis? Simple congenital ptosis, it is mainly a unilateral condition, but remember it can be a bilateral condition. And eyelid crease will be absent. We all have the creases in the upper eyelids. In these patients, the eyelid crease will be absent, and lid, leg, and down gaze. For example, if we look downward, so both the normal eyelids will also come downward, but the ptotic eyelid will remain in upward abnormal position. If we this is the eyelids, and we look in the downward position, the ptotic eyelid will remain in the upward position, and the normal will comes downward with the down gaze. This is called lid leg. And why this is happening? This is because there is some problem in the muscle, in the levator palpebrae superioris muscle congenitally, which reduce the function of this muscle and causes simple congenital ptosis. The second one is the Marcus-Gunn-Jaw-Winking syndrome, which is also called simple synkinetic ptosis. This condition affects about 5% of the children, and this is because there is the cross innervation between the oculomotor nerve and the mandibular branch of the trigeminal nerve. This mandibular branch of the trigeminal nerve normally supply the muscles of mastications, and the oculomotor nerve normally supply most of the extraocular muscles and the levator palpebrae superioris. So what is happening, that the oculomotor nerve now supplies the masticator muscles, and the mandibular branch supplies the palpebrae superioris muscle. So there is the cross innervation. The mandibular branch goes to the palpebrae superioris muscle, and the oculomotor nerve now comes into the mastication, the muscle of mastication. So this cross innervation causes this type of ptosis. When we tell the children to open their mouth, when they open their mouth, then their ptotic eyelid also comes to its normal position and becomes normal. So with the opening of the eye, with the opening of the mouth, the eyelids are also opening. This is called jaw-winking syndrome. Okay, so if they are eating, drinking, solving, in these conditions, their eyes will become normal and the ptotic eyelid will become normal. This is because of the cross innervation of the oculomotor nerve and between the oculomotor nerve and the mandibular branch of the trigeminal nerve. The third one is the blephropymosis syndrome. In blephropymosis syndrome, this is the condition of 4. What is 4? There are 4 signs and symptoms in the patient. First of all, there will be bilateral symmetrical ptosis. So there will be ptosis in both the eyes, and it will be symmetrical. Okay. There will also be telecanthus. Telecanthus is the distance between the distance between the two medial canthi of the two eyes. This is called telecanthus. So this distance will increases. This is called telecanthus. Epicanthus inversus. The third condition in this patient will be epicanthus inversus, that the skin of the lower inner, this is the skin of the lower inner eye, they will fold it. So this is called telecanthus. And the fourth situation is interpalpebral fissure will be reduced. So this is the interpalpebral fissure between the two eyelids. This is the vertical interpalpebral fissure. So this will be reduced in these type of patients. So this is the fourth situation is happening in the blephropymosis. syndrome. First is the symmetrical ptosis. Both the eye will have ptotic eyelids. Telecanthus, the distance between the two canthi will be increased. And epicanthus inversus, the skin of the lower eyelid of the two lower eyelid of the inner two lower eyelids will be folded. Okay, and the fourth one is the interpalpebral pressure will also be reduced. So when the eyelids is ptotic, so it will reduce the interpalpebral pressure. But in this type of patient, the interpalpebral pressure will be very much reduced, like in Chinese people. Okay, so these were the congenital ptosis. Now acquired ptosis. Acquired ptosis can be neurogenic, it can be myogenic, epineurotic or mechanical. So what is neurogenic type of ptosis? Neurogenic type of ptosis is any when there is problem with the nerves supplying the muscle of the eyes, then it will cause neurogenic type of ptosis. For example, neurogenic type of ptosis can be due to the third nerve palsy or it can be due to the Horner syndrome. What is happening in a third nerve palsy? When there is problem with the oculomotor nerve, okay, when there is palsy, when there is injury or trauma which damage the oculomotor nerve, and the oculomotor nerve we know that supplying all the most of the extraocular muscles of the eye and the levator palpebrae superioris, which is the main muscle involving in the lifting of the upper eyelid. Okay, so when there is problem with the third nerve, it will cause ptosis, neurogenic type of ptosis. It can be a complete and it can be a partial. If the third nerve is completely damaged, it will completely close the eye. So it will cause complete ptosis. Okay, and the complete palsy will cause complete ptosis. The eyelid will completely close the eye. But if it is partial, then it will cause the partial ptosis. The cornea, the half of the cornea or 2/3 of the cornea will be covered. Okay, it will associated mydrosis will also be present. Mydrosis is, for example, when there is the dilation of the pupil, this is called mydrosis. Why? Because the third nerve also carrying the fibers of the parasympathetic nerves, and this is the sphincter pupillae muscle, and this sphincter pupillae muscle is supplied by the parasympathetic fibers of the third nerve. When there is damage to the third nerve, then it will also damage the sympathetic fibers, and it will and hence what will happen that the dilator muscle cannot oppose the action of the sphincter pupillae muscle cannot oppose the action of the dilator muscle, and it will cause the mydrosis. Okay, now how the Horner syndrome can cause ptosis? The Horner syndrome is happening because when there is damage to the sympathetic chain supplying the eye, the muscles of the eye. Okay, so what will happen? There will be a meiosis. It is opposite to the mydrosis in the third nerve palsy. There will be meiosis as the dilator pupillae. This muscle is supplied by the sympathetic chain, and the action of this muscle is to dilate the pupil and to oppose the sphincter pupillae. So when there is a damage to the sympathetic chain, the sphincter pupillae will not be opposed, and what will happen? The sphincter will constrict and it will cause meiosis. This is called meiosis. Okay, the sphincter pupillae is not opposed by anything because of the damage to the sympathetic chain. The next thing, there will be ptosis. This is because we know that there are the retractor muscle, the molar muscle, as we have discussed in the chapter of eyelid. So when the molar muscle is also helping in the lifting of the upper eyelid. So when there is problem with this sympathetic, and this molar muscle is supplied by the sympathetic chain. So when there is problem with the molar muscle, it will cause ptosis, partial ptosis. Okay, and another interesting thing is that there will also be inverse ptosis. What is inverse ptosis? When the lower eyelid come to the upper abnormal position, this is called inverse ptosis. So the inverse ptosis, this is because the lower lid retractor is also supplied by the sympathetic chain. When there is problem with the sympathetic chain, both the retractors will not working, and hence the upper eyelid will come to the lower abnormal position, and the lower eyelid will come to the upper abnormal position. This upper abnormal position of the lower eyelid is called inverse ptosis. So, and the next thing is the anhidrosis. Anhidrosis is around the eye there will be no sweating. This is because of the damage, if there is extensive damage to the sympathetic chain. So these are the features of the Hartner syndrome. Now myogenic ptosis. In myogenic ptosis, there is some problem with the muscle itself, or there is problem in neuromuscular junction. For example, it can be myasthenia gravis or ocular myopathy. In myasthenia gravis, we know that myasthenia gravis is an autoimmune condition in which autoantibodies are generated against the acetylcholine receptors. When in myasthenia gravis the acetylcholine receptors are destroyed, so the muscle cannot be contracted, and what is happening that it will cause ptosis. In myasthenia gravis, the ptotic features are the ptosis can be unilateral or bilateral. It will worsen at night, and there will be the double vision diplopia because all the muscle they are asymmetrical involved, so there will be the diplopia double vision. Now the ocular myopathy is that when there is any problem with the muscle, extraocular muscle of the eye, for example, in chronic progressive external ophthalmoplegia, when there is the ophthalmoplegia of the extraocular muscle, it will also cause ptosis. When there is myotonic dystrophy in which the muscle is contract extensively and is not able to relax, so it will degenerate the muscle, it will cause the wasting of muscle. This is called myotonic dystrophy and will be discussed in the upcoming lectures. Okay, the ptotic features are, it is a bilateral condition, okay, and it is symmetrical. The ptosis will be symmetrical and there will be no diplopia. So there will be no diplopia, and the ocular movements, the upward, downward, lateral, medial, all the movements will be restricted because there is problem with the muscle. The muscle, there is ophthalmoplegia of the muscle, or there is myotonic dystrophy. So that's why there will be, the movements will be restricted. Okay. Now the next step is epeneurotic ptosis. And epeneurotic ptosis, what is happening? As we know that the levator palpebrae superioris muscle, the fleshy part is in the orbit, but the epeneurosis is in the upper eyelid. And through this epeneurosis, the levator palpebrae superioris is lifting the upper eyelid. Okay, so when there is problem with the epeneurosis of the levator palpebrae superioris, it will cause ptosis, and it is also a common type of ptosis. It can be due to what can cause the epeneurotic ptosis. It can be due to the dehiscence, okay. It can be due to dehiscence disinsertion, or it can be due to the stretching if the epeneurosis is stretched extensively. So these all conditions can cause epeneurotic type of ptosis. The last type of acquired ptosis is mechanical ptosis. For example, if there is some bump or lump on the upper eyelid, what will happen? It will cause the mechanical weight will cause the upper eyelid to come to the lower abnormal position. For example, chalazion. If there is the chalazion in the upper eyelid, if there is chalazion, okay, so this mass will create a downward force and will cause ptosis. If there is neurofibromatosis, okay, if there is, for example, if there is acute dacroadenitis, so these all condition will cause the mechanical force on the upper eyelid and will cause the upper eyelid to come to the lower abnormal position and cause ptosis. This is mechanical type of ptosis. Remember, there is one important point in the mechanical type of ptosis. If these conditions develops before 9 years of age, if the child is below 9 years, if these conditions are present, and if we are not able to treat them promptly and timely, what will happen? Because of this condition, the mechanical ptosis can cause, if the child is below 9 years of old, then it can cause amblyopia. Okay, these conditions all will be discussed in the upcoming lecture. Okay, so it can cause amblyopia, it can cause squint. Okay, so and these children, they will also try to tilt their head like this and to see through the lower normal position of the palpebral fissure. Now what are the clinical features of ptosis? The clinical feature can be, for example, I don't have duster right now, so I will write over here. So the clinical features of ptosis, they are, first one is there is cosmetic disfigurement. Okay, so cosmetic disfigurement will be present. The next one is amblyopia. Amblyopia is a serious condition. If the ptosis develops in a child below 9 years of age, what will happen? It will cause amblyopia. Why? Because when there is ptosis, so the major portion of the retina will not receive the light, so the brain will inhibit that portion of the retina, and it will cause, which is called amblyopia, and this condition will be discussed in detail in the upcoming lecture. So it can cause disfigurement, amblyopia. It can also cause children squint in the children, and these patient will tilt their head like this. They will tilt their head in order to see to the lower open position of the vision. Okay, so they will tilt their head in order to see to the lower open position. There will be the tilting of head, and there will be also the wrinkling. This forehead, there will be wrinkles. Why? Because they are trying to open the upper eyelid, so that there will be the wrinkle formation in the forehead. So the clinical features are, there will be cosmetic disfigurement. If the child is below 9 years of age, there will be amblyopia, squint, and there will be the tilting of head in order to see to the lower open position, and there will be the wrinkling on the forehead. So these are the clinical features of ptosis.